Hello, this is Dr. Bransler. Okay, I know I screwed up and didn't cover Chapter 10 the week I was supposed to, but I thought the information in Chapter 10 was important enough that we should go ahead and present that information to you. So this week's lecture focuses strictly on Chapter 10, but it's certainly an area of interest of mine since part of the focus is on healthcare quality. So these are the learning objectives. I won't read through them all. This is straight out of your textbook, and would encourage you to read through the chapter 10, because there's some very useful information in the chapter. So the focus of the chapter is on healthcare institutions and healthcare systems. So what types of institutions make up the U.S. healthcare system? The first is inpatient facilities. That would include hospitals, skilled nursing facilities, inpatient rehabilitation facilities, nursing homes, and institutional hospices. I will tell you that the rules have changed somewhat, but patients typically will remain in the facility for no less than 24 hours. In the Medicare program now, sometimes we can keep patients in a hospital setting for 24 hours or less in an observation status. But in general, for an inpatient facility, the patients will be there and stay at least one night, most of the time, though, more than one night. And then outpatient facilities, which is a host of different types of sites. Could be diagnostic imaging centers, outpatient surgical centers, physician offices. But in general, the concept of an outpatient facility is that you receive some clinical services by one or more clinicians in a setting that is not in a hospital. Now, the lines between hospitals and outpatient facilities is blurred some because many hospitals now do offer some outpatient services, even though it may be within the walls of a hospital. So again, those patients aren't staying in the hospital for 24 hours, but at OU Medical Center, as an example, we do lots of outpatient surgery in the hospital. We have a number of patients that come in for outpatient diagnostic imaging or testing. All of our gastrointestinal endoscopy is done in the hospital in an outpatient setting. Again, there's some blurring of the division, but again, remember, inpatients typically staying in the hospital for more than 24 hours. So I'm going to divide inpatient facilities into two broad categories. One is hospitals, which generally are designed for short-term stays, though I will tell you we occasionally will have a patient that's in the hospital for more than a year. There are both general hospitals and specialty hospitals. So in Oklahoma City, you may have heard of Bone and Joint Hospital, which is a specialty hospital that focuses only on orthopedic care, versus a general hospital, and that would be the hospitals like Integris, Mercy, St. Anthony, OU Medical Center, that provide all services. Another designation that you'll hear sometimes is safety net hospital. So OU Medical Center is generally considered a safety net hospital because we take care of a large proportion of the uninsured in Oklahoma City. Hospitals can be not-for-profit or for-profit. Most hospitals in the United States are not-for-profit. You can have investor-owned hospitals. So the McBride Orthopedic Hospital is investor-owned. And then there are government hospitals. Examples would include the VA system and the Department of Defense. So something like Walter Reed Medical Center that's part of the U.S. Army. Again, I just want to highlight that hospitals, even though they're typically called inpatient facilities, they often will and do provide an array of outpatient services such as radiology, outpatient surgery, and other services. The other type of inpatient facilities, long-term care facilities, we'll talk more about those. Typically custodial care with limited, the goal in most long-term care facilities is not to improve patient outcomes. It is to provide custodial care. So this would include nursing homes or assisted living facilities. Remember, it's an important point, but one that I find that some people don't get. You can't open a hospital or nursing home in the state of Oklahoma without a license. You're licensed by the state. In Oklahoma, licensure is a function of the State Department of Health, and it basically gives your board of directors the right to open the doors. You cannot open your doors as a hospital or a nursing home without a license. Hospitals specifically must have an organized medical staff and must provide 24/7 nursing services. So just remember the concept of licensure. Licensure means you can open your doors. It doesn't tell you anything about your billing or what type of hospital you are. I don't care if you're for-profit, not-for-profit, investor-owned. In Oklahoma, you cannot open your doors unless you have a license, and that comes from the state health department in Oklahoma. What does the governing board do? This is an important concept because licensure rules, these are the state licensure rules. Again, remember the state is licensing the hospital, and it states, the licensure rules state that the hospital shall have an effective governing body legally responsible for the conduct of the hospital as an institution. Specifically, it states that the board has these specific responsibilities. Fiscal responsibility to make sure that revenue is appropriately managed. But a lot of people don't know this. The board of the hospital, even though it may not be clinicians, it's often community folks, they're responsible for the quality of care, they're responsible for the safety of patients, staff, and visitors, and they're responsible to make sure that the only people who get medical staff privileges, the physicians in the facility, are qualified and competent to actually provide care. Now, think about that. In many rural communities, the hospital governing board is made up of local individuals. It may be lay people brought to the board because they have some expertise in financial management or other things, but they are responsible for the medical staff and the quality and safety of care that is delivered in the hospital. It's an important point to remember because it's been proven in malpractice cases that the board, the hospital, can be held liable for the actions of the physicians that they credential in their facility. So how does a board do that? Well, they delegate it. Again, the board of directors doesn't look at my credentials for hospital privileges. They delegate that to the medical staff. The medical staff has a credentialing committee that follows explicit guidelines for credentialing, and then we list those, and that information gets passed up to the board of directors. But again, just remember, the board of directors ultimately has responsibility for oversight of the medical staff, quality, and safety of care in a hospital. Well, another important concept is certification or accreditation. I know the book talks a lot about accreditation, but only talks about the Joint Commission, which is a bit out of date. So the first important point, if you open a hospital, you get a license so you can open your doors, and you want to bill the Medicare or the Medicaid program, and by the way, most hospitals do want to do that because that's such a big proportion of the population, you must be certified. How do you get certified? Well, the state health department can certify your hospital, and they have to follow something, if you look at my footnote, called the conditions of participation. There are a set of federal regulations for hospitals that explicitly state what kinds of programs you must have in place in your hospital so that you can be certified. And if you're certified, then you can bill the Medicare and Medicaid program. If you don't have certification, you cannot bill Medicare and Medicaid. Well, there's another pathway you can take, and that's accreditation. Accreditation means you go out and hire, contract with a private accrediting body, and there are 3 that accredit hospitals in the United States: the Joint Commission, the American Osteopathic Association's HFAP program, and then DNV, which is a program that is in Oklahoma. One of those 3, you go out and contract with them. They send in a team of surveyors, survey your organization, and if you get accredited, then Congress has given to those 3 organizations the deeming authority. In other words, if you get accredited, then you are deemed certified under the Medicare program and can go ahead and bill Medicare and Medicaid. So how do you choose? Do you go through the state health department and get certified, or do you pursue accreditation? Well, in Oklahoma, our health department is so underfunded that they don't have the staffing to do certification of hospitals unless the hospital can show some compelling financial hardship that would keep them from contracting with one of the accrediting bodies. So in Oklahoma, many of the rural hospitals in the state are still certified by the state health department. But most new hospitals in Oklahoma, virtually all new hospitals in Oklahoma, to open, you have to commit to going through the accreditation process, meaning you contract with one of those accrediting bodies. And then once you've done that, once you're accredited, then you're deemed certified and you can bill Medicare and Medicaid. The accrediting bodies, Joint Commission, AOA, DNV, are required to make sure as a part of their accreditation process that your hospital meets those federal regulations called the conditions of participation. So I know it's a bit confusing. You have to have a license to open your door. If you want to bill Medicare, you have to be certified. But most hospitals pursue accreditation, and if you achieve accreditation, then you are deemed certified by Congress and can therefore bill Medicare and Medicaid. There are other types of inpatient facilities, skilled nursing facilities, and inpatient rehabilitation. These are most commonly used for patients who've been in the hospital but are not quite ready to go home. So inpatient rehab, as an example, would be used often for a patient who's had a stroke, but they need intense physical therapy and occupational therapy, perhaps speech therapy, before they're ready to move to the next level of care. Skilled nursing facility is typically a little bit less intensive therapy than inpatient rehab. So you can get some physical therapy, but not as much. But you can do things like get intravenous medications. So an example, every once in a while we see a patient that has a heart infection. Those patients have to be treated with 4 weeks of IV antibiotics. And so oftentimes that's difficult to set up in the home setting, but we can send the patient to a skilled nursing facility where they can receive their IV antibiotics for the next 4 weeks. Both can be paid by Medicare or by private insurance. Each of those types of categories, inpatient rehab or skilled nursing, must justify the length of stay, the time they're keeping the patient. They must show that the patient is still improving and that they're offering services that they can't get in another setting. Okay, nursing homes, another inpatient facility. Again, this is primarily custodial care. We're not trying to improve patient outcomes. We're just trying to make sure that the patients are comfortable taking care of their daily needs, or sometimes called their activities of daily living, such as feeding, going to the bathroom, changing clothes, things like that. There are 16,000 nursing homes in the United States with about 1.5 million residents. There are a couple of different ways to pay for a nursing home. One way is to buy insurance, but honestly, most people haven't. It's quite expensive. If you're going to do it, you have to buy it usually in your 40s or 50s and pay for it for many years to cover the cost of a nursing home. Nursing homes are expensive. The other way is to qualify for Medicaid, but the only way that you can qualify for Medicaid is if you've spent all of your savings. And this is the way that many people in the United States end up getting Medicaid to pay for their nursing homes, and whatever savings they had through their lifetime, they have to, quote, spend them down unquote. So they spend all their money, and then they qualify for Medicaid because now they're impoverished, and Medicaid will then take over and pay for their nursing home care. Again, nursing homes are licensed by the state. You can't open your door without a license. They're subject to inspection. They have federal rules that they must follow. One thing you may know is that nursing homes are often subject of individual grievances, so a family can file a grievance with the state health department, and then the nursing home is subject to a site visit. There's another type of care called assisted living centers. These are typically less acuity than nursing homes. These are patients that can still perform their activities of daily living, but they can't live on their own. They need somebody to make sure they're eating, taking care of themselves, but they can pretty well do most of their activities of daily living. And then, of course, the final category I'll mention is hospice care. Now, there's inpatient hospice care and outpatient hospice care. The rules basically state that the provider must state that they believe that the patient has a life expectancy of 6 months or less. Nobody can guarantee a life expectancy of 6 months or less, so you don't have to be absolutely right, but you're generally putting people in hospice care who are in the process of dying, who have some terminal illness like cancer, for which they've refused further therapy or there's no further therapy available. I will tell you that hospice care is highly underutilized in the United States. We often wait until the patient is near death before we put them into hospice care, and it really should be done much earlier in the patient's course. What types of outpatient facilities exist? There are lots of them. The doctor's office, community health centers I'll talk about in just a moment. And then there are all sorts of outpatient surgery centers, diagnostic centers, places that just do CAT scans or MRIs, endoscopy units. So there are all sorts of outpatient facilities. They are not working under hospital license rules. They typically are far less expensive than outpatient services. The same services provided in a hospital are typically much more expensive, even though they're both outpatient, than if they're done in a true outpatient facility. The people that provide care used to was physicians. Now we call them providers, because in Oklahoma that includes physicians, physician associates, and advanced practice nurses or nurse practitioners. In Oklahoma, physicians can practice independently. Nurse practitioners can practice independently in Oklahoma with a few exceptions, for instance, prescribing of controlled substances, or and then PAs must work under the auspices of a physician. A physician has to agree to provide oversight for their practice. Community health centers, I'll just mention, your book talks a little bit about the Health Centers Consolidation Act in 1995. The concept of community health centers actually started in the Johnson administration in 1965. And these are the rules for a federally qualified health center. They must offer services to all regardless of the person's ability to pay. They can have a sliding fee discount program. So if a patient has some ability to pay based on their income, a federally qualified health center can charge some funds to the patient. They must be a nonprofit. They must be community-based. The majority of their governing board must be patients. They serve a medically underserved area or population. They have to provide comprehensive primary care services, and they have to participate in ongoing quality assurance programs. So the most notable federally qualified health center in Oklahoma you may have heard of is an organization called Variety Care. They have locations all over the state. Again, their board of directors is mostly patients. They are nonprofit, and they provide comprehensive primary care. They can, by the way, bill Medicare and Medicaid, and in fact, because of their status as community health centers, they get enhanced payment under those programs. Well, let's move on then to quality of healthcare services, and this is my area. I am the Enterprise Chief Quality Officer for OU Medicine, responsible for both our hospitals and our physician practice. And my job is to assure that we meet all the federal requirements, that we report the quality metrics that we're required to, but also to then work with the system to improve the overall quality of care. And there are three types of measures that we're going to talk about that we often use and work with. There was a famous physician, Avitas Donabedian. I had the distinct honor to get to lecture with Dr. Donabedian 25 years ago. He died probably 15 to 20 years ago now. But he came up with this conceptual framework of measuring quality. And he talked about the different types of metrics that we could use to measure quality. So he talked about structure measures, process measures, and outcome measures. Structure measures basically look at the physical plant and your infrastructure. Do you have fire extinguishers? Do you have safety lights in the hallways? Do you have exit signs that point you to the exit? Do you have the right committees in your hospital that are required under the conditions of participation? They're basic things that are easy to legislate. Process measures, however, are the things that we do to patients. So I'll give you an example in just a moment. And then outcome measures are the results of care. So as one surgeon once told me, patients who come into the hospital to have surgery want a good outcome. They don't care whether you meet the process measures or not. The process measures are often linked to outcomes, but the outcome measures are things like, did they die? Did they get an infection? Were they able to walk when they went home after their hip surgery? Those are the types of things that mean the most to patients generally. So I'm going to give you an example. Remember, my research focuses on the prevention of infections. So let's show you how you would use structure, process, and outcome measures to focus on prevention of infections. So this is Donabedian's framework. He originally published it in the 1960s, and then it was republished in 1988. And it's one of those conceptual frameworks that lives on today. But he basically said that quality can be measured by looking at structural metrics, process metrics, and outcome metrics. So structure we already mentioned. Do you have the infection committee? Remember, we're talking about how we prevent infections. So do you have an infection committee? Do you have the right equipment to deliver care without infections? Do you keep your physical plant clean? How do you sterilize your instruments? Structure measures tend to lend themselves well to licensing, accreditation, or surveys. Process measures, though, again, are the things that we actually do to the patient. So, did we give antibiotics before surgery? Because that prevents infections. We know that if you shave the skin before surgery, it increases the infection rate. Did we use proper drapes when we went to the operating room? One of the ways that we can keep patients from getting pneumonia in the hospital is to keep the head of their bed elevated. Or one of the most important things we do now is try to avoid putting catheters in patients into their bladder, because we know that the #1 predictor of a urine infection in a hospitalized patient is if we put a catheter in. So if we can keep it out, we dramatically reduce the risk of an infection. But then outcome measures, the end result, the thing that the patient experiences, the things that they care about the most. Did they get an infection? Did they get pneumonia? Did they get a bladder infection? Did they get a bloodstream infection? How long were they in the hospital? What was their mortality rate? How much was the cost to them in the hospital? Those are the outcomes. So this is the conceptual framework of quality that Donabedian put into place. And then another dimension, some people call this an outcome measure. Some people give it its own category, and that's patient experience or patient satisfaction. I'm not going to go into the details of the Agency for Healthcare Research and Quality, but they developed a standardized survey that's used on all patients when they go home from the hospital. And these are the types of questions that you get rated on now when a patient comes into your hospital. Did the nurses communicate with you? Did they listen carefully? Did the doctor listen to you carefully? Did they make their explanations clear? How responsive were the staff? If you pushed the call button, how quickly did they answer? When you were given a new medicine, did they describe it to you, explain it to you, explain the side effects? When you're ready to go home, you know what to do. When your follow-up appointment is. How clean was the hospital? How quiet was it? Was your bathroom clean? And then just what's your overall rating in the hospital? And as you see here, the response scale is always, usually, sometimes, and never. The only results that get reported is the percentage of patients who say always. You don't get credit for usually, sometimes, or never. You only get credit, and what's reported publicly is what percentage of the patients said always. Well, there are lots of different categories. This is a table in your textbook, table 10.1. I'm not going to read through it, but it's the dimensions of quality that were defined by the National Committee for Quality Assurance. So access, making sure you have qualified providers, you can stay healthy. We've talked about that before. The payment models are changing to reward staying healthy rather than doing more stuff, getting better, and living with illness. I like to use this model that comes from the Institute of Medicine, which is the framework that most of us in health quality focus on. The Institute of Medicine, in a seminal publication called Crossing the Quality Chasm in 2001, identified these 6 dimensions of healthcare quality. Care has to be safe. In other words, we don't hurt patients when they're in the hospital. It needs to be timely. Sitting around in a waiting room, sitting in a doctor's waiting room, that's wasted time. We need to figure out ways to reduce those harmful delays, make sure the care is appropriate and timely. Effective. The care that we give is based on true scientific evidence, not driven by whether we own the machine or not. It's effective. There's good scientific basis. Efficient. We avoid waste. We don't waste equipment, supplies, ideas, and energy. We don't waste the patient's time sending them to multiple different places to get one thing done. It's equitable. Every patient gets the same quality of care regardless of their age, their sex, their gender. We get blind to all of those things and focus on the evidence. And finally, patient-centered, that we're respectful of and responsive to the individual patient's preferences, so that if a patient doesn't want something done, that we honor those preferences. So these are the 6 dimensions of quality that are widely utilized today from the Institute of Medicine. Well, how can we coordinate care among multiple institutions that provide healthcare services? So a big part of my job now is exactly to do that. When a patient comes into the hospital, are they ready for the admission? Is all the paperwork? Is their H&P already done? Is their lab work? Whatever they need coordinated when the patient is in the hospital. Are we preparing for discharge from the moment they arrive at the hospital? Do we have a plan for post-acute care? We hope they can go home. If they go home, do they need home health care nurses to come see them? Do they have follow-up visits when they go home? If they need to go to skilled nursing or rehab, have we arranged that and have it coordinated so that they can get efficient care? Do we share their electronic medical records so the different care providers can actually see the care that the patient's getting? So there's all sorts of coordination that's needed, not only the clinician-patient relationship, but we have a preferred network of post-acute providers for OU Medicine now that we work with very closely. We meet with them every month to try to improve that coordination, financial coordination, recognizing that there are implications of cost of care for all patients. And then do we coordinate with healthcare and public health? Of course, there's no better example right now than the outbreak of COVID-19, where every time we see a patient that tests positive for COVID-19 right now, we clearly notify the public health, the state health department, and help them with the investigation of direct contacts. So these are some of the functions and challenges of implementation. with the various types of coordination. I won't read through the table. It's 10.2 in your textbook, but just some of the ideas about the intended functions and challenges with implementation. There are some systems that actually are very integrated. I'm going to highlight Kaiser Permanente. The Veterans Administration, remember the VA pays for the care for veterans. They own the hospitals. They own their own skilled nursing facilities, nursing homes. They run their own clinics. They have their own laboratory. Yes, there have been problems, but I will tell you that there are multiple studies that show that the VA oftentimes delivers higher quality care for some things because they are much more integrated. They have a single medical record. Doesn't matter which VA you go to in the nation. Any VA can see your medical records. They're very highly organized with that. Then there are all sorts of Medicare demonstration programs we've talked a little bit about before, accountable care organizations, bundled payments. I think I spent quite a bit of time when I talked about Chapter 11 talking about bundled payments, and one that OU is participating in, the Comprehensive Primary Care Initiative, where primary care practices like our family practice clinic are given extra dollars to hire social workers, case managers, pharmacists, so that we can deliver highly coordinated, integrated care and hopefully reduce overall spending on our patients. This is Kaiser Permanente. This is a simplistic model, but it shows you how they've worked. Kaiser actually sells their own insurance. So it's a very comprehensive plan. So an employer or individuals can buy health care from the Kaiser Foundation Health Plan. Then you receive all of your care, because you've purchased in, from the Kaiser Permanente medical groups. They own their own hospitals. So there's no incentive, because they're the insurer, to do more stuff again. So they have a bunch of hospitals, 22,000 physicians, 12.2 million members. Their goal is to reduce overall cost of care and to integrate care and coordinate it so that it's efficient and effective. So if you buy into the plan, you see a Kaiser doctor. If you need to be in a hospital, you go to a Kaiser hospital. They own their own outpatient services. The goal is to provide integrated care. And again, because Kaiser is the insurance company, they're paying the bills. So they don't benefit from more hospitalizations or more tests because they are the insurer also. So these are some of the services that they provide. They, obviously both ambulatory, outpatient care, ophthalmology, imaging, laboratory, pharmacy, ER, and hospitalization. They offer health education, preventive care, home health, labor and delivery, mental health services, occupational health, physical therapy. And their primary carers work very closely with specialists, surgeons, and hospitalists. Again, the whole focus here is that they've integrated all of this. They're the insurer and the healthcare delivery model. So they have no incentive to spend more of the patient's money on doing things that are unnecessary. It's a very comprehensive and highly regarded model of care. What about electronic medical records? I expanded this section from your textbook a little bit just because it's another one of my topics that I talk about often. The whole concept of getting away. When I was in practice early in my career, all of our records were on paper. We had this big room with files and paper charts. If I wanted to send a patient to the hospital or anything, I either had to copy it, fax it, or hand it to the patient so they could carry it with them. If I wanted to see the records from some other health system, I had to request it. It usually came to me by fax. Very, very fragmented and difficult. Many times I got a bunch of notes from the doctors whose handwriting I couldn't read. So there were piles of problems with paper charts. So these are some of the potential roles for an electronic health information system. Not only capturing the data, but doing order entry. One of the things I'll talk about is that now that we order most medications through the electronic medical record, we've actually reduced medication errors. Decision support, I'll show you an example of that, but that is when I'm sitting in the clinic with a patient, do I remember that they're due for their colonoscopy or their mammogram or their pap smear or whatever preventive service may be due? And that's one thing that electronic health records do very well, is they remind you that you need to do something. I mentioned electronic communication and connectivity between different healthcare systems, patient support, results management, administrative processes, registration, billing, and all of those things. And then all of the quality reporting that we have to do both as an ambulatory practice and also as a hospital system. We capture most of that information out of our electronic medical record, and it's also allowing us to start doing population health so that we can coordinate care for patients across settings. Technology in the United States, again, tends to be relatively fragmented. A lot of it has been, the basic and applied research has been paid for by the National Institutes of Health. A great example is the complete clarification of the human genome, which now has laid the groundwork for tons and tons of new diagnostic and therapeutic approaches. So I will tell you today that if you're getting cancer treatment, there's very, very likely that you're going to have some genetic profile that's done, because we know that different genetic profiles respond to different types of chemotherapy in different ways. And so it's actually allowed us to improve patient outcomes substantially. So your textbook, this is where I will deviate from the textbook just a little bit. It talks about all the potential benefits of using electronic health records to improve quality. And yes, I think you can definitely improve aspects of care with electronic health records. But I will tell you there's not much proof yet that that's actually happened. So my answer to the question, this was from a lecture I gave recently, is can you improve the quality of care with electronic health records? My answer was, well, probably. So there are definitely a bunch of features of the electronic health record that have made the work of being a practicing clinician easier. I can sit here at my home computer, look up a patient from anywhere. I can be on traveling out of state, can look up the records on my computer, and it's something I can never do before with paper records. Most doctors, if you ask them, once they've gone through what is usually a painful process of switching from paper to an electronic medical record, or switching from one electronic medical record to another one, most of the time after they get through that implementation process, they state they would not go back to paper records because, again, just the convenience of having access to the patient records 24/7 is a huge thing to improve overall quality of care. And there are some features, again, I mentioned that we know are better with electronic health records. We've reduced medication errors. The electronic health record will often prompt you if you make a mistake. And we're typing, we're not handwriting prescriptions. There's some reduction in redundant tests or procedures, because now I can see if they had it done at Mercy last week. So that will help me reduce some unnecessary redundancy, improve communication between providers. So we have functionality now in our electronic medical record in our office that I can see the records of, if the patient tells me they got care in Houston, there's a good chance I can type in Houston, Texas, and I can see their records from Houston. So definitely improved communication and made it easier to see care that's being delivered elsewhere. There may be some workflow efficiencies. You're not pulling out charts, scheduling, billing, and again, I mentioned remote access to patient charts is a fabulous feature, and it can be used for capturing data on quality of care at the point of care. However, two big problems here. One, particularly older doctors, many of them didn't type well. And so switching to electronic medical record was painful for them. Second, a lot of people, when they implemented electronic medical records, they were used to dictating. So when I was in practice, I dictated all of my office notes and put them in the chart. And so they kept dictating. And then what would happen is some nice transcriptionist would type their progress note, save it as a Word document, and it'd get converted to a PDF document, and then scanned into the electronic medical record. So it's there. It's in a list of documents, but it's not searchable because the data is in text fields in some type of a document. So it could be useful, particularly if we capture structured data, but a lot of people don't do that well. So there are features of known benefit. Decision support tools. Again, I'll show you that in just a moment, but it prompts appropriate care. And it can warn you if you're doing something stupid, like you're getting ready to prescribe a medication to which the patient is allergic. Great tool in the electronic medical records that you did not have access to in paper records. All the records are in a comprehensive file, but oftentimes page after page after page of redundant stuff. It can enable research because much of the data that we try to put in is searchable, promoting prevention. It may improve patient engagement through electronic devices. Of course, virtually every electronic medical record now has some type of portal that the patient can log into, see their own records, and to allow standardization, computerized physician order entry. So here's an example from OU Medicine's electronic medical record Centricity. We built this decision support tool several years ago because we were trying to help doctors. So hemoglobin A1C is a simple test that tells you how well a patient's diabetes has been controlled. And typically for most patients, we want to do it 4 times a year. That's what the American Diabetes Association recommends. Well, you can see for this particular test, it's going to prompt me and says, it's been more than 3 months. It's been more than 90 days, so I need to order the test. But blood pressures have been recorded. BMI, the body mass index, has been recorded. What about the LDL cholesterol? Well, we haven't done it in the past year, so it's due. Flu vaccine. Again, you're supposed to give a flu vaccine every year. All diabetics should get it because they're high risk for influenza. What this does is makes it easier. On one page, if I have a diabetic patient, and we set up this particular dashboard that any patient that has diabetes, this page will automatically pull up into the chart. When they're seeing the patient, they can tell what's due and what's not due. So it can really improve overall quality of care. Love that feature. This is the same thing for mammography, pap smears, osteoporosis screening, colorectal cancer screening, all the different tests. This patient, I don't remember how old they were, but colonoscopy was not indicated because the patient was probably less than 50 years, had had a mammogram within 2 years, so not needed at this time. But this particular patient may have been due for pap smear. So again, I love these features of decision support because they can make it easier to deliver preventive services, high quality care. However, despite all of that, I will just tell you, when you look at published studies, there's little evidence that patient outcomes have actually improved. The vendors, all the companies that sell electronic medical records, they don't compete on improved outcomes. They compete on price and other things. There's very little evidence that of return on investment. So again, if you ask most doctors, once they've converted, they won't go back. But overall cost of care haven't gone down. And sadly, one of the things that's happened is there's not a lot of interoperability. So if I send a patient on our campus to Dean McGee has its own electronic medical record, and they can send me a report, but it comes back basically as a PDF document that doesn't populate any of my decision support. So a lot of data tends to remain buried in text fields and doesn't get into those structured fields that help me do decision support for future care. Decision support in electronic medical record is only as good as the data you can put into a structured searchable field. If it's just a PDF document, a bunch of text, doesn't help me take care of patients. And patients don't necessarily like it that well. This is a survey of 2,000 patients, and I've highlighted at the end, 57% of the patients said their doctor spends more time looking at their computer than maintaining eye contact with the patient. Unquestionably, doctors spend more time just staring at a screen than actually staring or looking and talking to the patient. A lot of doctors get through their day and then go home at night and have to type the progress note. So there are some real challenges. So here's one of my huge things around the electronic health record. So here's a feature I love. This is useful. This is one of my patients, and I can look at their weight over time, their blood pressure, their cholesterol, their HDL cholesterol, their triglycerides. Everything's going the right way. Triglycerides down, HDL up. Their diabetes is getting better. They've lost weight. I love this type of a dashboard because it really gives me useful information. Never did I have this with a paper medical record. So there are features of the EHR I love. I absolutely hate this screen though. This is one of those where they have drop-down menus. So they have these template notes. Patient's blood pressure is, I can put well-controlled or uncontrolled or better or worse. I mean, you know, I can click on some drop-down menu and you get these junk notes at the end that frankly don't tell me a hell of a lot about the patient, to be honest. They're full of junk. And honestly, I highlighted down here, I can typically type a text note faster than I can go through the endless list of drop-down menus that show up in the electronic health record. So the next generation of, I think, of electronic health records are going to focus on efficiency, workflow, figuring out how to get the data where we need it so that it's structured, but don't just take tons of time clicking drop-down menus, check boxes, and things like that. So this is the feature, one of the features of the electronic health record I hate. And really good evidence that electronic health records have contributed to physician burnout, which is a huge problem in the United States. Well, how are quality of care in the United States being monitored? Well, there's certainly accreditation of academic institutions, accreditation we've talked about, credentialing of healthcare professionals. So I think I talked about in chapter 11 what process I have to go through to be credentialed and how they have to check my records. We have all sorts of requirements for continuing education, recertification, and maintenance of your license. So in fact, I spent a good chunk of today at a continuing medical education course so I can ensure that I maintain my license. And another one that we talked about again in chapter 11 is this concept of pay performance, getting paid more for delivering high quality, low cost care. Another thing that's being done is the use of evidence-based recommendations and guidelines. So when we built that diabetes dashboard, we looked at the most contemporary American Diabetes Association recommendations for care. And the decision support that we built into the electronic medical record is based on evidence-based recommendations. We don't recommend things that aren't recommended, but we tell clinicians explicitly what is recommended for that particular patient. Of course, hospital privileging, credentialing, we've talked about accreditation of additional healthcare organizations, patient safety efforts, and malpractice liability. I'm not going to talk about malpractice liability, but still an enormous problem in the United States, though there's little evidence that malpractice alone is driving most healthcare costs. I mean, clearly there needs to be reform to malpractice and the liability for healthcare, because it's been demonstrated over and over and over again. Most medical malpractice cases are focusing on bad outcomes, not bad care. And that's a huge challenge with the system. And that'll become apparent when I show you this next example. So a number of years ago in my role in health quality, I was asked to review this chart. just recognize there are tons of things that are going on in healthcare to try to improve the overall quality and reduce errors. But this was a patient, and I called him Sam, who came into a hospital outpatient department. So we talked about it was at a hospital, but it was an outpatient department. He was expected to go home, and he was having a minor laparoscopic operation, a gallbladder operation with a laparoscope. So the anticipation was he'd come in, he'd have the 3 tiny incisions, his gallbladder would be removed, he'd recover for a couple of hours and go home. He had done everything right. He saw his primary care physician, he saw the surgeon, and he visited with an anesthesiologist several days before surgery. Everything was done correctly. The surgeon ordered the preoperative lab that he wanted and had the anesthesiologist assess the patient. So you would think this was a guy, and I think he was in his 40s, that you would expect to come in and have an uneventful surgery because he had had all the preoperative assessments. Well, this is an important point to understand. Human beings, by their nature, make mistakes. It's inevitable. We cannot expect error-free human performance. Most bad things that happen in medicine, most errors happen because of bad systems, not bad people. Healthcare workers come to work, they don't come to work with the intention of hurting somebody, but they work in a system that's complex and things fail. So it's a very, very important concept because most of the time when something bad happens in medicine, we could have predicted it if we looked at the system beforehand. So this is an example, and it's a famous one by James Reason. It's called the Swiss cheese model. So think about it. If you have a family member in the hospital, there's a doctor taking care of them, some nurses, respiratory therapist, maybe a dietitian, maybe a surgical tech or someone else. All of them are human. By nature, remember, all humans make mistakes. It's inevitable. There is no such thing as error-free performance. But what we try to do in medicine is build multiple layers between the error and the patient to keep the error from getting to the patient. So in this example, this is a patient going to surgery. Now again, surgeons, surgical techs, lab techs, others are not perfect. They may make mistakes, but we try to reduce those mistakes. We use pre-printed orders so we don't forget to order something. We've updated our job descriptions. We have training policies. We now use surgical checklists. We do a timeout before every operation where somebody goes through that particular checklist to say, have we looked at the lab? We got the right patient? Are we operating on the right body part? Who are the people standing around the table? Have we ordered blood clot prevention? If we think we may need blood, do we have blood immediately available? So we go through a checklist. We reconcile the medications. We do something in the operating room called team steps, where we teach all of the team members in the operating room how to work together to deliver safe and high quality care. But remember, the most famous Institute of Medicine report was called "To Err is Human," and it made the point that human error is inevitable. Well, here's what happened to Sam that day. See, Sam went in and saw those doctors and had his preoperative lab drawn, but nobody saw the lab. In fact, it was probably buried in some papers on the surgeon's desk. The physician wasn't called, so the physician was not notified of the lab result. So the first hole lined up. It wasn't available in the surgical chart, where typically when they checked the patient before they went into the operating room, they would have looked at it. At that time, there were no timeouts. There was no preoperative checklist that said, did we review the lab, that you would have to check a box. It didn't have that at that time. So what happened that particular day for that patient was all the holes in the Swiss cheese lined up. Again, this is the James Reason model of healthcare errors. And for Sam that day, all the holes lined up. Well, the story, the rest of the story is the patient's lab work had come back and showed that the patient had a congenital or born with blood clotting abnormality. His blood didn't clot right. And when they looked at the lab, he had a very long coagulation times on his lab work. Nobody would have operated him had they looked at it. So they took the patient to surgery. He was given anesthesia. They started the procedure with the laparoscope. And as they got towards the gallbladder and started clipping arteries, he started bleeding. And he started bleeding a lot. They called in another surgeon. They opened the belly. But a long story short, the patient bled to death on the operating room table. Again, the primary care physician had taken care of many patients in the past. The anesthesiologist was seasoned and very good. The surgeon was a good surgeon. These were not bad people. The system wasn't designed to protect the patient. There was no checklist. Nobody asked about the lab. It was buried in papers on a desk somewhere. So that's the concept of errors where we can use electronic systems, checklists, and other things to improve overall quality of care. That's the stuff we have to do in healthcare if we want to deliver high quality care. You cannot fix people because errors are inevitable. You have to redesign the system to make it safe. Hope it's been useful. And if you have questions, here's my email address. Thank you.